I'm here to teach you about the Columbia Suicide Severity Rating Scale and how you'll be able to use that in your work to better identify people who are at risk for suicide and get them to the care that they need. I'm going to talk to you a little bit about the history of the scale. We'll go through all of the questions and definitions on the scale, and we'll talk about how to triage using the instrument. I'm going to talk to you about two different versions of the scale. One, what we consider the full scale, which is about 10 to 24 questions, and what we consider our short screener version, which is just 2 to 6 questions. And you'll see quickly why, how they're both useful, and we'll talk about which situations you might want to use one over the other. But before I begin with my trainings, I always remind people that suicide is a very personal issue for almost all of us. Many of us here on the call this morning may be survivors who have lost a family member or a friend or a client to suicide, and many of you may in fact be attempt survivors. And so I urge you to, pay attention to how you're doing later today, and do something nice for yourself, tonight or over the weekend. We don't take care of the caregivers the way that we should be. So we know what a global public health crisis suicide is. Nearly 1 million people die from suicide around the world every year. In our country, or worldwide, suicide is actually responsible for more deaths than natural disasters, homicide, and war combined. In our country, suicide kills more people than car crashes. Yet we see all kinds of public health efforts at preventing deaths from car crashes. Seatbelt programs, don't text and drive signs on the highway, but we don't see those kinds of efforts aimed at suicide. And that's why Thomas Insel, the director of the National Institute of Mental Health, said that suicide is the under-recognized public health crisis because it does not get that attention that it truly deserves. And we know that it really touches everyone. It's estimated that about 135 people are impacted for every single death that occurs. It's actually the #1 killer of teenage girls across the globe, and it's the second leading cause of death among adolescents and young adults in our country. And we've seen a 60% rate increase in the last 5 years in our youngest kids between 8 and 12 years old. So it's not unusual these days, although it's rare, to experience a suicide in someone as young as an elementary school student. Now, we know how common thoughts and suicide behaviors are in our adolescents from the Youth Risk Behavior Survey that the Centers for Disease Control does every other year. And what our teens tell us themselves pretty much consistently year after year is that about 8% will make a suicide attempt every year, and about 17% will seriously consider it. So if you take a classroom of like 35 students, in that classroom alone, 3 students will attempt suicide this year. It's usually 2 girls and 1 boy, because girls attempt suicide twice as often as boys do. But boys die by suicide 4 times as often as girls, and there are actually a couple reasons for that. The first reason being that boys tend to choose a much more lethal method when they make their suicide attempts. They tend to choose either firearms or hanging, which are lethal the majority of the time, and girls tend to choose overdoses with medication, which are very rarely lethal. The other thing is that when we look at the difference between the boys and the girls, what we see is that there's still a much greater stigma for boys in asking for help. When they did autopsy studies of teens in New York City who had died from suicide, they found antidepressants in the bloodstream of 4 times as many girls as they did of the boys. So the girls were actually actively out trying to get some help, whereas boys tend not to. And, there's actually a strong relationship between suicide and school violence. So we saw in the Safe Schools Initiative study that the Secret Service did that about 78% of attackers showed a history of suicide attempts or thoughts prior to their attack. And so we've been saying since Columbine that if we screen our high school students, we not only will find students who might be suffering in silence, but we may also prevent a tragedy like Columbine or like Parkland from happening. And, you know, even a third of them, close to a third of them report that the suicide was their motivation in their attack. And yet only a third of them had ever had a mental health evaluation, and only 17% were diagnosed. So we know we're not finding the kids that we need to find. But deaths from suicides are really just the tip of the iceberg. So we lost about 43,000 adults to suicide in 2015. But for those deaths, there were 1.5 million suicide attempts, and there were almost 10 million adults who seriously considered suicide in the United States. So the numbers of people attempting and seriously considering it far outnumber the number of people who actually die from suicide. It's estimated there are about 25 attempts for every one death. And so our job and what the SSRS can help you do is really figure out which ones of those folks are at those highest risk points for making a lethal attempt. And, you know, we see suicide in all of our medical illnesses, not just in our mental health illnesses. So if you have, for example, cancer, you're 18% likely to have suicidal thoughts, independent of any depression you might have. And similarly for almost all other health issues, arthritis, chronic pain, cancer, heart attack, stroke. They all increase your risk for having suicidal thoughts or behaviors. So it's not just in our mental health clinics that we need to, you know, look and to find these folks, but we also need to look in the nurses' offices. We need to have this be part of our medical evaluation as well. And, you know, it's a crisis in just about every sector that we look at. It's the #1 cause of death in our jails. The leading cause of death of youth in juvenile detention, and it's actually often the #1 cause of death of first responders. In 2014, we lost more firefighters to suicide in the U.S. than we lost in fires. And police officers who we train quite frequently how to ask these questions tell us that they're not just happy to know the questions because they want to use them in their communities, but they also are happy because they can, you know, screen their partners, and they know what they should worry about if they start having these thoughts themselves and can get the help that they need. And this is breaking but not really surprising news. It turns out that a large portion of our opioid overdoses are actually suicides and aren't necessarily being categorized that way on autopsies. And it makes a lot of sense when you think about it that a lot of people who get into opioid addiction are self-medicating either a chronic pain condition or a mental health issue like depression or anxiety. And this is, you know, really alarming, but as a result of the opioid epidemic and the suicide epidemic, the United States is now the only developed nation in the world that has seen its average life expectancy decrease over the last 2 years. Every other developed nation, it's been increasing steadily, but we've seen it decrease, and that's because we are losing a lot of young people to suicide and to opioid overdoses. Now, while the greatest numbers of suicides happen in our cities, the greatest rates of suicides happen in the rural parts of our country. And there are a couple reasons for that. The first being that they tend to have populations that are spread out across a great distance, and sometimes that gives them poor access to mental health care or medical care. And before I came to help direct the Lighthouse project here, I was the youth risk behavior, the youth suicide prevention director for the state of Georgia. I was there on the Garrett Lee Smith grant, and what we found in Georgia was, you know, just that if you know, in the rural parts of the state, when families were stressed and someone was out of work and they were struggling to put food on the table, they didn't drive 45 minutes to take their kids to a mental health appointment. It just becomes a low priority when they're really struggling to make ends meet. The other thing about the rural parts of our country is that if you look at all of the statistics and measure them up against suicide, if you look at age and gender and socioeconomic status, levels of education, what you find is that the one demographic factor that most closely tracks alongside with suicide are rates of gun ownership. So the more guns in a community, the more suicides you'll have. And these two maps look at the rates of suicide by county in the United States and the rates of gun ownership by state. And you can see that the states with the lowest rates of gun ownership, California, Illinois, New York, New Jersey, Connecticut, Massachusetts, they all are very dark blue in the above map and have the lowest rates of suicide. And this data really makes it very dramatic, the point very dramatically. This is a look at the states with the highest rates of gun ownership and comparing them to the states with the lowest rates of gun ownership in groupings so that we have about 189 million residents in each group. And when you do that, the states with high rates of ownership have about guns in about 56% of the homes, and the states with low rates of ownership have guns in 20% of the homes. And when you do that, you see that the numbers of non-firearm suicides are roughly equal, about 8,700 men in the low ownership states and about 8,100 in the high ownership states, and for women, about 3,500 in both groups. But if you look at the numbers of firearm suicides, it's 4 times as great for men in the states with high ownership, 4,000 compared to 16,000, and almost 10 times as many for women, only 300 in the states with low ownership compared to 3,000 in the states with high ownership. So what we see is that just simply having access to firearms increases the rates of suicide in your community. And I'll tell you a little bit about what's going on in Oregon. Oregon in 2016 had the 11th highest suicide rate in the United States. 1 out of every 4 of your suicides are veterans. Over 80% of the gun deaths in Oregon are suicides. Nationally, it's about 60%. And eviction or loss of a home was a factor associated with 7% of your suicides between 2009 and 2012. And as far as the methods that Oregonians have been using for suicide, about 60% of the males use firearms. About a third of the females use poisoning. About a third use firearms, and about a third use hanging or suffocation. And the overall totals are about half of your suicides are by firearm. And this is a look at your counties and their suicide rates. And you can see that down in the southwestern part of your state and along the coast, you have higher suicide rates, and then over towards the eastern part of your state are where you have your highest suicide rates. And as far as what Oregonian students have been saying, in the last survey that was done, you saw that about 6% of your 6th graders said they attempted suicide, 9% of your 8th graders attempted suicide, and about 8% of your 11th graders attempted suicide in the past year. So again, if you take a large high school of like 1,000 kids, each year in that high school, about 90 of them will make a suicide attempt. And, I talk to superintendents and principals all the time, and when I tell them this statistic, that this is what your students are telling us, this is not what's going on in some other community, they are flabbergasted, shocked. They They don't know who those kids are. They know of maybe a dozen of them because, they're keeping track of them, and they're, the social workers are staying, know that they're seeking help in the community, et cetera. But the vast majority of these kids who are making suicide attempts in your high schools, you don't know who they are. And we should talk about depression because it's a really important, closely linked illness to suicide. It's actually on its way to becoming the most debilitating disease in the world. It's the most debilitating disease in our country and in all other high and middle income countries. It's actually the number one cause of work-related absence in our country. And that actually costs our workplaces $23 billion a year in lost productivity from just those days that people miss from being depressed. And so it not only impacts individuals and families, it actually also impacts our economy. And unfortunately, we know people who need treatment for mental health issues don't get it. While we know most people with mental health issues are not suicidal or homicidal for that matter, we do know that 90% of individuals who do die from suicide have an untreated mental illness at the time of their death. And for 60% of them, it is depression. But we know that, it's estimated that about somewhere between 50 and 75% of adults who need treatment get no treatment. For children and teens, it's about 70% of them that have depression don't get treatment. And for more than 8 out of 10 of our adolescents and college students who have died from suicide, we have never seen them getting any consistent treatment prior to those deaths. So I want to debunk a few myths about suicide. The first being that if someone's really suicidal, they're probably going to kill themselves some point in their life no matter what you do. You can't really stop somebody. We know that this is false, and that's because multiple studies have found that more than 90% of attempt survivors, even those who make very highly lethal attempts but survive them, do not go on to die from suicide. Most people are suicidal for a short amount of time. It's one of those symptoms that comes and goes with levels of stress. And so if you help somebody through a suicidal crisis, they may never become that suicidal ever again as long as they live, and you may, in fact, make a lifelong impact on them. Asking a depressed person about suicide may put the idea in their heads. We know that this is false. When I first graduated from social work school, I had a job. My first job was working in an inner-city mental health clinic with adolescents in Boston. And I was terrified to ask those teenagers, have you thought about killing yourself or have you made any suicide attempts? I was afraid. I think that if I started talking about it, somehow it would, make it more likely that they would go ahead and make an attempt. And what we know from the last decade of research is that's absolutely not the case. That talking about suicide does not suggest it or make it more likely that someone will make a suicide attempt. In fact, even when we've screened an entire high school of students, we don't see an uptick in any of their ideation levels or attempt levels. In fact, open discussion is more likely to be experienced as relief. And, of course, the bigger risk is when we don't ask these kinds of questions. Someone making suicidal threats won't really do it. They're just looking for attention. We know that this is false. People who talk about suicide or express thoughts about wanting to die are at risk. And even if they are, are so-called frequent flyers, people who talk about it a lot, this is particularly common in folks with borderline personality disorders, they do go on to make attempts. And we do need to take each of those, statements seriously. God forbid the time that we don't take it seriously is the time they feel that nobody's listening and they go on to make an attempt. So we need to listen and act on all utterances like that. There's no point in asking about suicidal thoughts. If someone's going to do it, they won't tell you. We know that this is false. Most people will tell you if you ask them, although they might not come out with it on their own. And they're often relieved when you do ask. And that's because ambivalence is characteristic in 95% of people who are suicidal. The wish to die that accompanies suicidal thoughts is in conflict with the natural human species' desire to live. And it's actually very hard to overcome that natural desire to survive and make a suicide attempt. And that's why we see contradictory statements or behaviors often in people who are suicidal, because they can be suicidal one minute and not suicidal, a few hours later. I heard a story about a man who, the same week that he made a suicide attempt, he also booked a family vacation for the next school break. So he was thinking about something positive in the future at the same time that he was thinking about, killing himself. And we know 80% actually will give some kind of hints or warnings to friends or family. And I think that number is probably even higher these days because it's so easy now on social media to post something that, is vaguely suicidal or has some kind of depressive message in it. And we know people want to be asked. We do a lot of work with Kevin Hines. Kevin Hines, if you don't know who he is a man who survived jumping off the Golden Gate Bridge, which is lethal 99% of the time. And he tells his story with a lot of drama, but he was a 19-year-old kid who had a psychotic depression. And he tells the story of that day. He made a pact with himself that if just one person asks me, why I'm crying, what's going on, I'm going to get some help. I'm going to tell them everything. And so he gets on the bus and is crying on the bus, and people are changing their seats so they don't have to sit next to him. He gets to the bridge, and the bus driver says, "Come on, kid, I got other stops to make," and, shoos him off the bus. He walks up and down the bridge 2 or 3 times. Nobody says anything to him. And then finally he's approached by a tourist, and he says, he thinks to himself, finally someone's going to ask, and I'll get some help. And what she says is, "Can you take my picture?" And he decides then that nobody cares, and he jumps off the bridge. And he says that he instantly realized everything in his life that he thought was unfixable was totally fixable, except for the fact that he had just jumped. And he goes on to say that most people considering suicide want somebody to save them. And what we need is a change in culture where we're not afraid to ask these kinds of questions. And then finally, if you stop someone from killing themselves one way, they'll just find another. This is the argument for means safety, which is actually the most evidence-based prevention mechanism that we have. And what means safety is when you can put a little bit of extra time between someone who's actively suicidal and them having a lethal method in their possession. And so we know firearms are lethal 85% of the time, with hanging second at 70%. But things like overdosing with medication, cutting oneself, jumping off a high building are lethal, much less of the time compared to those other things. And so, making it a little bit harder for someone to get a firearm can actually make a tremendous difference. And we have lots of historic examples of how just reducing access to lethal means does bring down suicide rates. And so it goes back all the way to the 1950s. In the 1950s, in Great Britain, they used to use a very toxic coal gas in their stoves. It had a very high carbon monoxide content, and people were dying by asphyxiating themselves with the gas in their cookery. And so that's where the euphemism for suicide, to put your head in the oven, comes from, if you remember hearing that. I remember hearing that a long time ago as a kid. And what they did in the late 50s was they started phasing out that gas and replacing it with less toxic gas like we have. And when they did that, they reduced their carbon monoxide poisonings by a third without seeing an increase in other methods. So when people thought this was the way they were going to do it and it didn't work, or they realized they couldn't, they didn't go and then find another way. It gives time for that ambivalence to act. And that's what we're looking for in means safety or means restriction. In England, again, in 1998, they were having a problem with Tylenol overdosing. And so they introduced a law where they have to sell Tylenol and other medicines in blister packs, where you have to punch the pills out one at a time. And when they did that, they saw a 44% reduction in Tylenol overdose over the next decade. Now, in our country, we buy Tylenol in bottles of 500 at Costco, right? That's what I have at home. We don't have these efforts at prevention that some of these other countries have engaged in. And lots of examples about how making it a little harder to get a firearm reduces suicides. In New Zealand in 1992, they passed stricter licensing laws and required locked storage and reduced gun suicides in youth by 66%. And in the military in Israel in 2006, they restricted gun access for off-duty soldiers so that their soldiers, when they're on leave, can't take their guns home with them. They have to leave them on base. And when they did that, the suicide rate in their military dropped 40%. Because they didn't have the guns at home when they might be in an emotional situation with their families, and so people were not then able to attempt suicide. And this is a woman from Maryland who says that she had postpartum depression with her second child, and things got really bad. And she started planning suicide, but at the time it felt completely normal to her. She decided she needed something reliable because she didn't want to survive the attempt and then become a medical burden for her family. But she didn't have a gun, and so finding a manner that was fast and reliable took a long time. And it was during that time that she recognized what was happening and got some help. And she says that was a long time ago. She's fine now, but she would most likely not be here to write this had there been a gun in her home at the time. And that's why we're now working really closely with the firearm community to make sure that folks who sell guns, who own guns, who work around guns have this information about the risk and know what to do and how to get someone help. So we have a poster that we've provided to gun shops that have the SSRS questions on them and tell people how to get some help if they're feeling depressed. The gun shop owner doesn't want to sell a gun to somebody and then hear a day later that they used it in a suicide attempt. They feel, quite guilty about that. And since we know that 2 out of every 3 gun deaths are suicides, we can make a tremendous impact in this way. And Dr. Posner, who's the director here, is actually doing some work with the NRA right now to help with getting this message out. So we know that we can prevent suicide. We can prevent it with means safety. We can prevent it by providing treatment with medication and psychotherapy. But first, we need to identify who needs the help. And the field of medicine for many, many years was plagued by a problem where we didn't have a common language for how to talk about suicide. So you would see the exact same suicidal behavior, and it would be called 10 different things: suicide threat, suicide gesture, non-serious suicide, parasuicide, and we didn't have a good understanding of what kind of risk to assign to those types of descriptions. And so we couldn't get the right help to people back then. And we also couldn't do good research on suicide because our epidemiology was also impacted by not having this common language. So the Columbia Suicide Severity Rating Scale has really gone a tremendous distance in providing this common language. It was developed in a National Institute of Mental Health study to look at what was helpful for adolescent suicide attempters. It was done at Columbia here and with University of Pennsylvania and University of Pittsburgh, and it was called the TASA study, the Treatment of Adolescent Suicide Attempters study. And in that study, these authors, who were the leading researchers in suicide at the time, brought together all of the measures that they could find and developed the CSSRS using their knowledge of what was evidence-based in predicting risk. And since that time, it's been used by millions and millions of folks. It's available in 120 languages. English and Spanish you can download off our website, but if you need another language, we're happy to see if we have it and provide it to you. The list of languages is on our website. It takes a very short time to administer, anywhere from just 30 seconds to a couple minutes. It's considered the most evidence-supported gold standard tool, and it can be used by all ages. We've seen it used successfully with kids as young as 4 or 5 in preschool, and with adults, well into their old age. And the definitions from the CSSRS have actually now been adopted by the Centers for Disease Control and are being recommended to any researcher who's doing suicide research. So they have a link to our website right in their researcher's booklet, and they have our definitions, but they also have a list of the unacceptable definitions, things we should stop saying, things like parasuicide and suicide threat and suicide gesture, but also things like completed suicide and successful suicide. Right? You complete a project and you're successful at your job, and we want to take those positive words away from an event like suicide. And so the recommended language now is just to say died from suicide or attempted suicide, and to not give any other kinds of language around those terms. And when we have a good, strong definition for what is a suicide attempt and what is a death from suicide, it's very, very easy to do that. And the CSSRS is now part of the Toolkit for Zero Suicide, which has been developed by the National Action Alliance for Suicide Prevention. And if you go to the National Action Alliance's website, to their Toolkit for Zero Suicide, you'll see that the CSSRS is part of the program that they recommend for evaluating risk. And the second part of the Zero Suicide Toolkit that's very important is what we call safety planning. And so in New York State and in other places, different hospitals and communities that are zero suicide models, they've embraced both the CSSRS and safety planning. And at the end of this webinar, I'll tell you when the next webinar is going to be, which is going to be a training on this safety planning model. Now, Centerstone has become the poster agency for zero suicide. They were an early adopter, and you can watch videos on the Zero Suicide website of their director talking about how they implemented. But briefly, what they did is they implemented a program where they screen everyone at every service delivery point. They're an outpatient mental health center. And if you come in, and see 3 providers, one for medication, one for individual therapy, and one who's running a group that you're in, you'll get asked the short screener 3 times that day. And they've just made it part of their, natural language that, when you check in, this is what we're going to ask. And, we very closely keep track of suicidal thoughts and behaviors. And then if they score as high risk, they get placed into a suicide-safe pathway. And that gives them access to means restriction education, weekly appointments, and if they don't show for an appointment, they have a dedicated call center that continues to do outreach to try and get them back into care. And as a result, they've actually been able to see their outpatient suicide rates decline by 65% in the first 10 months in the state of Tennessee. Now, we really have moved towards embracing a prevention model where we believe everyone everywhere can ask these questions. So you don't have to be a mental health provider or have any kind of mental health training to successfully ask these questions and get somebody to the help that they need. So when we train in behavioral health care settings, we train paraprofessionals and peer counselors, we train receptionists and nurses' aides and custodians and janitors. When we train in schools, we like to see that teachers get trained and safety officers get trained, and even the bus drivers and cafeteria workers and coaches. We recently trained all of the coaches at Princeton University here in our neighboring state of New Jersey. And that's because, you never know when you're going to have somebody who's in a position where they look at somebody, don't think they look so well, and can ask them these questions. We're not training janitors how to be mental health clinicians, but when they have the questions they need in case they need them, that creates a safety net in a community. And this public health approach, as opposed to the medical model we used to use, where we just relied on, clinicians to do this kind of work, is where we need to head if we're going to make an impact in the suicide rate. And so we've developed these pocket cards for folks to have the short screener right with them wherever they go. And it started as a result of our work with the Air Force. The Air Force said, we'd like to give these questions to everybody in the Air Force. And so we created these pocket cards that say, ask your wingman, care for your wingman, and escort your wingman. Because ACE, Ask, Care, Escort, is one of their mottos. And so it has the CSSRS questions on the back of the card, and it's highlighted in yellow, orange, and red to tell them which are the highest risk questions, and gives them some information at the bottom for what they should do next. Now, as a result of how successful this was, being given to every airman and their spouse, we've moved into the other branches of the military, but we've also created them for community use. So we have them for first responders, for parents that say ask your kids, for teenagers that say ask your friends, and for teachers that say ask your students. And you can download these off of our website. You can print them out, 4 to a page, laminate them, and cut them up and distribute them, widely in your community. And we really encourage that. And what the military now, the Department of Defense, has said is we must go beyond this medical model. And when the Marines were the first ones to do that, they embraced the CSSRS for screening and rolled it out across all of their military bases. This was about 6 or 7 years ago now. And when they did that, they didn't train their mental health staff how to use it. They trained their financial aid counselors, they trained their chaplains, and they trained their lawyers and paralegals, because the number one precipitating event now before a Marine suicide is having a legal problem. So they get arrested for a DUI or a domestic violence charge, and they're ending their lives by suicide because of the impact that has on their careers. So now every time a JAG lawyer meets with a Marine, the lawyer asks the short screener questions and then takes them to behavioral health when they score as high risk. And so when we create a community that has all of their systems linked together, where the schools know this language and how to use it, when first responders know it, when hospitals know it, when their primary care doctors know it, when the prisons and jails know it, that's when we create this synergy of use and create this safety net. And, somebody in a training, once said, I think I get it now. When the school nurse is doing the same assessment that the EMT will understand and that the admitting nurse in the hospital will understand, we're going to get that kid from where they are now to where they need to be in the fastest possible time. And since asking with an everyone, everywhere approach, Utah has become the first state to embrace that as an entire state. And they trained everyone from their sexual assault advocates to all of their first responders and every teacher in the state of Utah. And when they did that, they saw in 2014 the first decrease in suicides in the past 8 or 9 years when they embraced this everyone, everywhere model. And we really believe it's so important because we need to screen and monitor for suicide the same way we do any other vital sign or any other illness. Because we know that half of people who die from suicide see their primary care doctor in the month before they die. And many adolescent suicide attempters will go to the ER for an illness or an injury and not there for a psychiatric reason, and they don't get asked these questions. And so if we ask these questions in all of these places, we know that we will find people who need help. And screening programs work. Screening in high schools have been shown to better identify students with mental health issues compared to just allowing the clinical professionals to screen on their own with no tool. And when both were used, it was extremely effective. And in colleges, screening has shown reductions in suicide. In primary care settings, they've increased detection of depression and other issues. And so Parkland Hospital in Dallas, Texas, has actually now become the first hospital to embrace universal screening. Everyone who comes into the hospital for any service gets screened with the CSSRS. And they reported out after they screened their first 100,000 patients that about 1.8% needed follow-up. follow-up evaluation. And what you'll see later on is that that's roughly the number that we see over and over again who need help. People worry that if we start screening everyone, we're going to just have all these people in need. But it turns out, for risk, that it's about 1% of the people who you screen will turn out to need some additional assistance. And that's why the Joint Commission now is promoting the CSSRS for its accredited hospitals so that they can screen for suicide. So let's talk about the actual instrument itself. The CSSRS is simply, in its full form, a 2-page assessment of suicidal thoughts and suicidal behaviors. Suicidal thoughts is broken up into 2 sections of 5 questions each, one on the severity of their thoughts and one on the intensity of those thoughts, 5 questions on each of those things. And then behaviors assesses 4 behaviors and the lethality of any attempts. So for the first part, ideation severity, that's a 1 to 5 rating with 5 questions where they increase in severity as you move through them, from a wish to die to an active thought of killing oneself with plan and intent. Those 5 questions are on both the full and the screener CSSRS. And then if you're doing the full version, it has those 5 follow-up intensity questions. And then as far as behaviors are concerned, for the first time, the CSSRS is an instrument that looks at all the relevant behaviors that pertain to suicide and increase someone's risk. It used to be that we just asked people, have you ever made a suicide attempt before? And when we did that, we missed the person who had practiced tying nooses in their basement, or who had, gone to the ledge of a roof but came back down after they changed their mind. Things now that we know have just as much risk of someone making an attempt, but we never used to ask them. And each of these behaviors have the definitions of them right on the form and standardized probe questions that you can use if you choose to ask in the easiest way. And then and those 4 behaviors get assessed on both the full and the screener version. And then there's a lethality section that's in the full version only. So it's a semi-structured interview. There are probe questions on the form that you can use, but it's not required that you ask, all of them or any of them exactly as they're written, as long as you are confident that you've collected the information you need to collect to go back and fill out the right boxes on the form. Most people, when they first start with it, or if they're using a self-report version that the clients or students can fill out themselves, will use the questions exactly the way they're written. But once you're comfortable with them, you can make them feel more, like they're part of your vocabulary and, like they're more conversational. That's perfectly fine. Another fundamental tenet of this CSSRS is that you can use multiple sources of information to score it. Most of the time, the person you're talking to will give you the information you need, but if that person can't or they won't, then you can use a parent or another family member or caregiver's information. You can use past medical records. This can be really helpful for children or adolescents who may not give the same information their parents give. It's very helpful for very, very young kids, which is why the CSSRS can be used with kids who are in preschool, because you ask their parents, did you hear any these kinds of things, or did you see your child do any of these kinds of behaviors? And so, for example, a peer comes to your office and says that his friend posted on Instagram that he wants to die. You can then check off wish to die, and then you can go and interview that other student. So the ideation section, again, is 1 page on the full version, and the first 5 questions are in both the full and the screener. And those questions are, have you wished you were dead or wished you could go to sleep and not wake up? And have you actually had any thoughts of killing yourself? Those are the first 2 questions. If the second question is no, you skip 3, 4, and 5 and move on. But if the second question is yes, they have had thoughts of killing themselves, you ask 3, 4, and 5, which are subcategories of thoughts and give you more detail. Question 3 is, have you been thinking about how you would do this? So do you have a method in mind. Question 4 is, have you had these thoughts and some intention of acting on them? So did you think you were going to do it, or do you plan to do it? Are you going to go through with that? And question 5 is, have you started to work out the details of how to kill yourself? And do you intend to carry out this plan? You can't have a method thought of or intent to act on your thoughts or a plan and intent if you've never had a thought, which is why you can skip 3, 4, and 5 to move more quickly if question 2 is no.
So tell me, what brings you to see me today?
I've been feeling kind of crummy, problems with my family, and things at work aren't going so well.
Have you been feeling depressed?
Oh, I've been crying a lot, and it's hard to get out of bed in the morning. I guess you could say I'm depressed.
I see. So tell me, over the last month, have you wished you were dead or wished that you could go to sleep and not wake up?
Sometimes I think things would be better if I were dead.
I understand. But do you actually wish you were dead or want to be dead?
Now and then, yeah.
And have you actually had any thoughts of killing yourself?
Yeah.
And have you been thinking about how you might kill yourself?
Sometimes I think about jumping in front of a train or a bus.
But you wouldn't really do that, though.
No way, no way.
See how asking the wrong question can shut down the conversation? Watch now how asking the right questions using the prompts on the SSRS can get you more accurate information.
Sometimes I think that I'll jump in front of a train or a bus.
Have you had these thoughts and had some intention of acting on them?
Yeah.
Can you tell me a little more about that?
Last week I really wanted to do it, but I chickened out.
Okay, so have you started to work out or worked out the details of how to kill yourself?
No, nothing specific.
Thank you for being so honest with me.
Thank you.
So in the example you just saw, the answer circled would be a 4, intent only, not intent and a specific plan. In this next example, a 5 would be indicated. Watch.
Sometimes I think that I'll jump in front of a train or a bus.
Well, have you had these thoughts and had some intention of acting on them?
Yeah.
Can you tell me a little more about that?
Last week I really wanted to do it, but I chickened out.
Okay, so have you started to work out or worked out the details of how to kill yourself?
Yes. I got a subway schedule, and I saw that there's a station that between 7 and 8 o'clock at night, there aren't many people there, and that's what I was going to do.
Well, do you intend to carry out this plan now?
I worry that I might.
Okay. Thank you for being so honest with me. We're going to get you some help right now.
Thank you.
You see, it would be a 5 because he had intent and a specific plan with the intent to act on it, all the details worked out, etc.
So I'm going to go through a few examples, which I know you won't be answering, but I will answer for you. This patient reported he first started thinking about killing himself when he was 12. He thought about how easy it would be to pretend to fall in front of a bus before it could stop so that it would look like an accident. Although he thought about it often, he said he didn't have the courage to do it. Is that a plan or is that a method? We know that that's a method. A plan is much more detailed. A plan is something like, next Wednesday at 3 o'clock when my mom's working the late shift and she can't stop me, I'm going to come home from school and I'm going to take all the pills that we keep upstairs. A plan has the what, the where, and the when, and the intent to act on it. Now, once you've established the highest severity of ideation for an individual, if you're doing the full version, you'll move on to the intensity of ideation section. And these are 5 follow-up questions about the frequency of their thoughts, the duration of their thoughts, how easy or hard is it to control their thoughts, did they have any deterrence to acting on their thoughts, And what were the reasons for their thoughts? Was it to stop the pain they were feeling, or was it for some other reason, or was it a combination of the two of those things? And so for frequency, you ask how many times did you have those thoughts, and there are multiple choice answers you can choose from, whichever one most closely matches what their response is. For duration, when you have the thoughts, how long do they last? For controllability, can you stop thinking about killing yourself or wanting to die if you want to? How easy or hard is that? For deterrence, are there things, anyone or anything, family, religion, pain of death, that stopped you from wanting to die? And then what's the reason? Is it to end the pain you're in? In other words, you can't go on living with this pain or how you're feeling, or is it to do something else, get attention or revenge or reaction from others, or is it a combination? And so for intensity, obviously, if thoughts are more frequent, if they're longer in duration, if they're harder to control, if there are fewer deterrents, and if it's to stop pain, then you would worry more about someone. Now, you can add up the multiple choice answers in this section of 5 questions, and you'll get something between 2 and 25 for a score. But we don't have a cutoff in this section. There's no connection between the answers and imminent risk. So it can just give you some additional information to help inform your clinical judgment. Now, of interest, if you're working with adolescents, Cheryl King, who does work primarily with adolescents, found that that second question on duration is the most predictive question for teenagers. So if teenagers are thinking about suicide and it's lasting all day long, they can't stop thinking about it, that's when worry should be increased for teens. So let's talk about behaviors now. The full CSSRS, as you know, has questions on 4 specific behaviors. And those behaviors begin with an actual suicide attempt. And the definition that we use at Columbia and that the CDC uses and the Department of Defense uses is that suicide attempt is a self-injurious act undertaken with at least some intent to die as a result of the act. Now, the first part says it's a self-injurious act. There doesn't actually have to be any injury or harm, just the potential for injury or harm. So if, for example, someone puts the gun to their head and the gun fails to fire, or they lay down on train tracks and before the train comes they get off, as soon as there's potential for injury, as soon as they pull that trigger, it rises to the level of a suicide attempt. The second part being at least some intent to die, where some is the important word. As long as their intent is non-zero, but it does not have to be 100%. You know, often people have mixed motives when they make a suicide attempt, but as long as a little part of them wants to die when they do it, then it elevates to a suicide attempt. So you can ask somebody, did you ever try to kill yourself before? And they'll say, not really. But if you follow up with, well, you know, when you were cutting yourself, did any part of you want to die? If they say, yeah, I guess a little bit of me wanted to die, then that elevates it to an attempt. And then finally, the last part, as a result of the act, meaning that the intent and the behavior must be connected in some way. The behavior that they engage in must be because they want that behavior in some way to kill them. Now, one of the other great aspects of the CSSRS is that you can infer intent. And we can do that in 2 different ways. The first is that if somebody denies that they have intent to die, but that they know that what they did could kill them, and they did it anyway, then you can infer intent. And then in what we call clinically impressive circumstances. That's where what they've done is so highly lethal that it couldn't be considered anything other than a suicide attempt. So that's somebody who takes 200 pills or sets themselves on fire. We wouldn't, call that anything else. And, the importance of this, the ability to infer, came when we were training in Army hospital. And they told us about a man who was hospitalized, a soldier hospitalized there, who had shot himself in the face and survived. And when they were able to ask him, were you trying to kill yourself when they did that, he said no. And to them, if they couldn't have put on his record that he made a suicide attempt, he wouldn't have gotten the help that he needed. So a suicide attempt begins with the first pill swallowed or the first scratch you make with a knife, and you can ask, have you made any suicide attempts? Have you done anything to harm yourself or done anything dangerous where you could have died? And the reason why there are multiple questions for this behavior is because we're trying to really differentiate it between non-suicidal self-injurious behavior. Now, non-suicidal self-injurious behavior, or NSSIB, is when you engage in that behavior when it's 100% purely for reasons other than to end your life. Now, that's usually to affect one of two things. It's usually to either affect how someone feels internally, so they feel a lot of pain and hurt, and cutting themselves or burning their skin helps to release that pain, or they're feeling numb inside, and those self-harm behaviors release adrenaline, which makes them feel alive. Or it's to affect external circumstances. That's the person who is trying to get sympathy or attention, so they pretend that they're suicidal. That's the person who comes to the hospital and pretends they're suicidal because they're homeless and it's cold and they want to get into a warm room for the night. So I'm going to skip these examples of suicide attempts, and you can look at them on the slides if you want to have some examples, but in the nature of time, I'm going to skip over them. So this is what the actual attempt section looks like. You can see it has this boxed-in question, or did you think it was possible you could have died from what you did? That can help remind you that you can infer intent. And then it also has subject engaged in non-suicidal self-injurious behavior down at the bottom. Now, the reason the authors added this particular question to the scale was because they were finding that if they asked all the right questions and found out that an episode of cutting, for example, was non-suicidal, if that wasn't there at the bottom, they just had a no checked on the page. And they didn't have a place where they could say, no, actually, we asked all the right questions and determined that this was a non-suicidal behavior. Now, the other behaviors that we didn't choose to ask about before are an interrupted attempt. That's when someone starts to take steps to end their life, but someone or something stops them. Someone who has a bottle of pills or a gun in their hand and someone grabs it, or someone on the ledge poised to jump. And you ask, has there been a time when you started to do something to end your life, but someone or something stopped you before you actually did anything? And the third behavior is an aborted or self-interrupted attempt. That's when a person begins to take steps toward making an attempt, but they stop themselves. They change their mind before they actually engage in any behavior. And that's the person who is planning to drive his car off a road at high speed, and on the way there, he changes his mind and comes home. Or she picks up a gun thinking about suicide and puts it back down. And she asks, you can ask, has there been a time when you started to do something to end your life, but you stopped yourself before you actually did anything? A good example of this behavior came when we were training a hospital in Detroit, and they told us about a man who was in their ER after driving his car intentionally into a wall. And when they asked him this question, he said, you know, there were 4 other times that I felt bad and drove really quickly towards that wall, but stopped before I got to it. And no one's ever asked me a question like that. So imagine if a week before he had been at his primary care doctor for his annual physical and the doctor or the nurse had asked these questions. Maybe they would have gotten to him before he actually had any injury. And then finally, preparatory acts or behavior. That's anything other than a verbalization that has suicidal intent. So things like assembling the means to kill yourself, writing a suicide note, giving your valuables away, looking up online ways to kill yourself. And you can ask, have you taken any steps toward making a suicide attempt or preparing to kill yourself, such as, and the examples are in the question for you. A good example of preparatory behaviors we were training a VA hospital, and they told us about their most recent suicide death was a veteran. He was in his 70s. He had been in to see a psychiatrist, denied their usual questions, but upon his death from suicide, they found that he had been putting clothing in different bags and labeling it for charities and stockpiling food for his pet for 6 months. He was making preparations. And, what this told that system was that, we never would have found him if we, didn't know that this was an important question to ask.
Have you made a suicide attempt in the past 3 months?
No, not really.
What do you mean by not really? Have you done anything to harm yourself?
Well, last month I took a handful of pills because it's like even my parents can't see how much pain I'm in.
Did any part of you want to kill yourself? Or was it 100% to get them to pay attention to you?
I guess a little bit of me wanted to die. Either way, I would have been better off.
Were there any other times you did something like that?
No.
Okay, I see. And in the past 3 months, have you ever started to do something to end your life? That someone or something stopped you before you actually did anything?
A friend of mine took a bottle of pills from me because I was thinking about taking them.
Was there any other time that happened?
No.
Okay. And has there been a time when you started to do something to try to end your life, but you stopped yourself before you actually did anything?
No. Not that I can remember.
Have you taken any steps toward making a suicide attempt or preparing to kill yourself, such as collecting pills or getting a gun, giving valuables away, writing a suicide note?
I wrote a note to my friend telling her that she could have my CD collection if anything ever happened to me.
Is that the only thing you've done like that?
This one time, I put a bottle of pills underneath my pillow. You know, just in case.
So, just those 2 times?
Yes.
Thanks. I appreciate how honest you've been. So, when you took the pills, what happened after that? Did you go to a hospital? Did you seek medical attention?
Well, they were just vitamin pills. So no, I didn't get any medical attention.
I see. Thank you. Let's see if we can get you some help.
Thanks.
And we know that all of these behaviors are prevalent. This top graph looks at 30,000 administrations of the SSRS to depressed study subjects. And what we found was in those high-risk behavior answers, only 13% were actual suicide attempts, and 87% were these other 3 behaviors. So if all you ask about was, have you ever tried to kill yourself, you will miss the vast majority of people engaging in these worrisome behaviors. The other thing that the graph shows is that, again, people worry about asking lots of people. If we ask a lot of people, aren't we going to have a lot of work to do? And in this 30,000 depressed study subject example, there were 1.7% with worrisome answers. And in the bottom example, which was 3,000 vets who were seeing a psychiatrist, a very high-risk population, they found only 14 had a positive screen. And upon follow-up, only 5 of them had to be hospitalized. So 0.5% needed more evaluation. Again, you can look at these examples on your own. Then the final section is on lethality. And that section is for what actually happened if there were any actual attempts medically. And so, for example, if it was a cut, you'll ask them, did it bleed a lot or a little? Did you have to get it bandaged? Did you have to get it stitched at the hospital? Did you have to stay overnight because you lost consciousness from the blood loss? And you'll assess that on a scale of 0 to 5, with 0 being very minor physical damage or no damage at all. And then the final question on the scale is on potential lethality. And that's there if there were any attempts where there was no medical damage at all. You have a place where you can mark that if they were likely to try that same behavior again, what is the likelihood of injury or death? And that's either a 0, 1, or 2, with 0 not likely to injure them next time, up to 2 likely to result in death. And the reason the authors put that there was because for those rare cases where somebody does, use a gun and the gun fails to fire, or they lay down on tracks and then get off the tracks, they wanted a place to mark very clearly that if they, even though there was 0 medical damage, this doesn't look like a very lethal attempt. If they were to try it again, it's likely to result in their death the next time, so that you would have a way to see it actually was quite a lethal attempt, even though there was no medical damage. So when you're doing the behavior section, you check all the behaviors that apply, but only if they're discrete behaviors. So for example, if somebody collects pills and puts them under their bed and then takes them in a suicide attempt, you're not going to count that as both a preparatory behavior and an attempt because they were sort of a combined episode. You're just going to count that as an attempt, and you can put the details in your narrative. And a reminder that you're supposed to assess ideation and behavior, regardless of whether there's any ideation. You move on and ask about behavior because while it's rare, we have seen some individuals who will say, I never thought about suicide before in my life, but when I was feeling really bad at that party and I was drunk, I took a handful of pills because I didn't want to wake up the next day. And because of the impulsiveness of it, they won't say they had any thoughts. But they will say they had a behavior. So you do need to ask about behavior, even if thoughts are negative. And then it's important to listen to what the person in front of you is telling you their motivation was when they did what they did, and not to rely on what we think about what they did. And this can be very important for very young children who will do things like put a shoelace around their neck or put their head in a pillowcase. And we've seen some folks who won't take that seriously because they think, oh, well, they can't really die from that. But we need to listen to what they're saying their motivation is when they engage in those behaviors, no matter what those behaviors are. This is also can be very important for people who might be psychotic. So we had a psychotic girl hospitalized here at Columbia during the study, and she had made several suicide attempts in her life that were very serious. But she had made one suicide attempt where she had ordered so much Chinese food because she believed she could eat herself to death. And while we know that's not possible, we still need to call that a suicide attempt because she is saying that she wanted to die when she did that behavior, and she connected them in her mind. So this is what the screener 6 questions looks like. It has the same first 5 questions, as you can see from the full version, but then the behavior question is all 4 behaviors combined into a single question. So it says, have you ever done anything, started to do anything, or prepared to do anything to end your life? And it has examples of all 4 behaviors. Now, the time frame for worry is very important. If you do the full version of the scale, the first time you see someone, we recommend doing the lifetime recent version, which gives you a lifetime history and as well as a recent risk profile. And so for lifetime, for ideation, you would be asking them about the time they felt the worst in their life. Because Aaron Beck showed a long time ago that, the time someone feels the worst or most suicidal in their life is very predictive of how the rest of their life will go. And so even if it was 20 years ago, you're asking about the time they felt the worst. Then for figuring out whether they need to be hospitalized today or they need to go for further evaluation today, you're assessing the past 1 month for their thoughts and the past 3 months for their behavior. When the authors were developing the scale, they looked at all of the research on risk and found that after these time frames of 1 month for thoughts and 3 months for behavior, the risk for an imminent attempt drops dramatically by more than 50%. And that doesn't mean that someone who's had a behavior 4 months ago is not at risk, but the risk is significantly lower that the authors felt that it didn't qualify for an imminent risk picture. Now, these time frames are flexible, and if you do want to change them and ask about a longer time window, you can. But just remember that if you ask about a longer period of time, you're going to get more positive answers. And so that 1 to 2% that we talk about really happens in this time frame of 1 month and 3 months. And we believe that monitoring is critical. And so we have versions of both the screener and the full version that have one column for scoring, and it says since last asked. And so we encourage that, just like Centerstone, you can use it every time you see a client, and you can simply say to them, since the last time I saw you, have you had any of those suicidal thoughts that we discussed, or have you done any of those behaviors that we went over? And that's all you have to ask for follow-up is really question 2 and 6. And so some hospitals are using this on inpatient units every nursing shift as part of their mental status check. So they do it every 8 hours. And again, it's possible because it's really just, a 10-second question. And then if that's yes, then you'll take out the form and follow up and ask some more detail. But all you start with really is questions 2 and 6. So what do we worry about? The biggest worry happens when there is a yes to question 4 or question 5 or there's any behavior. So question 4 and 5 are when there's intent to act on their suicidal thoughts. The difference between 3 and 4, 3 is where they say, I thought about using my service weapon, but I would never do that. I have family I care about, etc. And a 4 is where they say, I can't really promise or tell you that I'm going to be safe, or I really intended to do it that time. When intent appears is when we worry the most. And we used to think it was a plan that was important, but it's not the plan itself, actually. It's the intent to act on it. And then for behavior, any of those 4 behaviors in the past 3 months results in high risk. And, what this does is it provides the scientific best data to inform your clinical judgment, right? We're never going to have a perfect system for assessing imminent risk. There are always going to be people who won't tell you, and you'll have no's throughout the form, but you're still going to be worried about them. And there will be people who will say yes to everything because they want to malinger in the hospital. And you're going to have to add to these answers your clinical judgment when making a management decision. And so if it's very important and has the most impact when you can embed this kind of tool into your electronic health records so that the information travels with the person and can be seen by anybody who's doing work with them. So this is New York State's electronic health record for Medicaid, and they have the SSRS right in it. And if you have one of those high-risk answers, a 4 or a 5 in the past month, or a behavior in the past 3 months, you get the highest level of alert. It says suicide warning in red at the top of your chart. At Centerstone, if you have one of those high-risk answers, your name changes to the color purple in everybody's appointment calendar. So anybody who's a purple on your schedule list and they're coming in to see you, is in that high-risk suicide pathway, and you should be doing careful follow-up with them. So the CSSRS toolkit is extremely flexible. We have a pediatric or cognitively impaired version of the scale, which is used for very, very young folks, those preschoolers or kids who are, 4, 5, 6 years old, or for someone who has a cognitive age in that range. And that's also available on our website if you want to download it. It changes the way the questions are asked so that they can be understood a little bit easier, and it omits the things that very, very young kids don't understand, like some of the intensity questions. Little kids don't often write wills, so that's not in there. And then you can take our questions, cut and paste them into any assessment you're already using. So this is a nurse's mental status checklist from a prison in California. They took our questions and dropped them right into their mental status check and added them to what they were already doing. And you can add your own questions to it. So this is a cover page with risk factors that the military National Guard thought were important to ask, things about state of service, how many deployments, any marital stress, using drugs or alcohol, any chronic pain, things that they know are high risk in their population. And this is what Tennessee has done for their crisis assessment tool. For all crisis assessments, they use the short six-question screener, and they use a checklist of risk and protective factors that the authors of the CSSRS developed. Again, this is also available for download on our website at no charge. You can use the checklist of risk and protective factors if you'd like. And so, as you can imagine, this is having a strong impact on care delivery and service utilization and stigma reduction. We used to use the PHQ, and a lot of people still do, use the PHQ-9 for assessment of depression and suicide. PHQ-9 is a great measure of depression, but it's a really lousy measure of suicide. The 9th question is the suicide question, and it says, have you had thoughts you would be better off dead or of hurting yourself in some way? Now, better off dead is not considered suicidal by anybody. Suicide researchers don't see an increase in risk. And hurting yourself in some way can be non-suicidal self-injury. And so when Cleveland Clinic looked at 523 patients using both the CSSRS and the PHQ-9, they found 24% had a yes to item 9, and only 6.2% had positive screens with the CSSRS. And they actually found a few people with the CSSRS that said no to question 9, that they would have missed entirely. And it is helping redirect resources to where they need to go. So this is a look at ER one-to-ones and psych consults in Reading Hospital before and after using the CSSRS. The red line is where it was before, and the blue line is where it was after. And so they were able to redirect millions of dollars, and so has a lot of other hospitals, by making sure just the right people get the one-to-one care that they need. And schools have been, a tremendous area of controversy when it comes to referring to the ER. For nobody's fault, but for wanting to keep kids safe. 4 hospitals in New York City took a look at the kids the schools here were sending and found that 60 to 97% of those referrals didn't require hospitalization. And so the Department of Education here in New York City said, the great majority of children and teens sent to the ER for evaluation are not hospitalized, do not require the level of containment, cost, and care in an ER evaluation. And in fact, ER evaluations can be traumatic for kids and families and may actually be less effective in getting them what they need. And, imagine if the first time a kid says, to their teacher or, counselor, I wish I was dead, parents immediately get called. They are angry because they have to leave work. They take them to the ER. They sit in the ER for 8 hours because they're not emergent, and they get evaluated, and they get sent home, and they're in school the next day. Do you think it's likely that that kid will tell a teacher the next time they feel bad? It's probably not, and we see that with adults too, that having inappropriate evaluations in the hospital actually shut people down to care when they, eventually need it. And so New York City, for their first screening effort, trained 38 middle school nurses, the nurses in 38 middle schools, and they reported back to the Board of Education that they found an estimated 100 students that they identified that would have been missed if they had not been trained in the CSSRS, and dramatically reduced the unnecessary referrals. And so now it's in every middle school and every high school in New York City. It's in every school teacher's hand in Israel, and all the teachers in many other places use it as well. And it's actually now moving into school policy. And so this is from the state of South Carolina. This is a look at a policy recommendation that they've made to all the schools in South Carolina that include assessment and screening with the CSSRS and recommended next steps for high-risk students. And when we ask the CSSRS questions, we actually protect ourselves from liability. People worry that if I start asking these questions and something bad happens, aren't I opening myself up to a lawsuit? And what we see is that it actually protects you. A medical malpractice attorney was interviewed for an article in Crane's magazine, and what he said was that if this is the gold standard and you're using it, that's the most protection that you can have. We all have some risk because we're in the mental health field, but when you're using something scientifically based like this, as opposed to just your own questions, that's when you have protection. And someone at a training recently said, you know, people don't get sued for bad outcomes. They get sued for negligence. They get sued for not doing something. And in fact, all of the successful lawsuits against schools that I know of when there's been a suicide have been when someone knew something and didn't say anything, not because they did a thorough evaluation or asked these types of questions. And you know, when we just ask, we break the silence and stigma and give permission for people to connect, which builds paths to openness. Just having this common language in this training is actually an intervention in and of itself. And what the suicide prevention director for Israel said to us is that it's not only saving millions of lives, it's literally changing the way we live our lives, breaking down barriers that have been built over thousands of years, but we're just one nation, and every nation deserves this life-saving tool. So there are lots of ways your peers can get trained. We recorded this so that it will be available on your website, but you can go to our training page on our website and you can find ways to access pre-recorded trainings or trainings in lots of other ways. If you want to contact us directly, you can write to kelly.posner@nyspi.columbia.edu. And you can also just go to our website and fill out a Contact Us page at cssrs.columbia.edu. And I want to remind you that Part 2, Safety Planning Webinar, will be April 30th at this same time. Your Zero Suicide Academy is set for September 18th to 19th. And you'll be able to get this recorded webinar at healthOregon.org/SBHC. So I want to open this up to taking some questions, but I know that there are 100 of you on the call, and if I unmute your phones, nobody will be able to hear anything. So if you could write questions into the chat box, we'd be happy to answer them. So while you're thinking of questions, Dr. Posner just came in and she'd like to be able to say a few words to you. So hold on a second.
Hi, everybody. So I'm here in case, and I can help answer some of the questions that you might be typing, but I just wanted to tell you that we're, very excited to be doing this. We are particularly eager and excited to optimize impact in schools for all of the obvious reasons. And as Adam probably told you, all 50 states have gone top-down in policy, and it's involved schools, a long time ago. But we can really, really continue to do better and make models like in Israel, how every school teacher has it in their hand and every coach should, and state officials say to me, parents are using it to save kids' lives. Like, we're really eager to help you in the thing that you want to do, which is save lives even more. So excited to be here. And as Adam said, we welcome any questions at any time about a case, about a system, about anything we can do. We're a 24-hour service center. So let me see, where's the first one?
First one is where the access.
Oh, this is Megan. I did just want to share that when Adam was talking about, building this into your electronic health record for school-based health centers in Oregon that are using Ocean Epic, it actually is already built in. I believe you have to request access to it, but I believe it's already built in, and it's I believe free to members who use Ocean Epic.
Yes, well, and that's great. And as you may have heard, there's this flexible toolkit, and you can use different things for different times, and you should just know what you have access to. And all of the forms are accessible on our website, as well as the training you can link into for other people if you want to watch it again with all the videos and whatever is helpful. And so, somebody asked if there's any data around LGBTQ, and it's been used for that reason for a very long time, and we work with all the organizations, and any kind of study or thing that is looking at suicide risk has typically used this, so it's very indicated in all of that. Yeah, and so there's a question about how often you monitor, and what I always say is as often as you can, right? So 50% of suicides see their primary care doctor. We should be thinking about this like blood pressure, but ongoing, monitoring is people or kids who weren't suicidal become suicidal, and because it's a minimum of 2 questions, maximum of 5, and it's helping decrease workload, it's only upside, because God forbid the time you needed to ask is the time you didn't ask. So in a hospital, it's 3 times a day at every mental status check-in. Every time, in a setting or a chapel or something, in any setting like that, every time there's a communication, like saying, how are you, you can use these questions. So really at every visit or every contact is what we think is all upside.
Should they screen every student or just
Yes, and definitely you want to definitely screen everybody, right? Because if you don't ask everybody, you're not going to find the people suffering in silence. You cannot rely on just triggering. It's like blood pressure, right? Whether you have a problem with blood pressure or not, you're going to get your blood pressure taken and beyond. So really everybody. And as we kind of reduce the stigma and normalize this kind of questioning, that's what's happening, and that's really what's indicated. How do we doing the screen?
Sending them to the hospital and they come back the next day.
Yeah, so I'm not sure if you went through this, the dramatic redirecting of resources. So the first time, Columbia has these research-supported thresholds for imminent risk. In the past, nobody knew who to worry about, so everybody would be taken. Now the policeman doesn't have to hospitalize unnecessarily, and you know what happens when they do? It shuts that kid or that person down from treatment when they actually need it. So we find consistently that using those evidence-based thresholds, only about 1% need a next step. So I'll never forget, in Tennessee, if you saw the linking of systems slide, they said it's so important that the school nurse is doing the same thing as the EMT as the hospital. That not only quickens care, it allows us to identify people who wouldn't. But I'll never forget, the example that I've heard 200 times over, the boy sitting in the principal's office for 9 hours waiting for the EMT to get there, who never needed to be sitting there in the first place. So now, because we have this more targeted identification of high risk, and because of that liability protection, that doesn't have to happen anymore. And I know I heard Adam start to talk about this. We don't have a perfect formula. We may never. So people used to be afraid to ask. So now, as you said, where it's gone with the Columbia, that if you use these questions, it protects you. So you don't have to, even if God forbid something happened, you did what you needed to do. And I want to say, that, like he said, that people say it also helps with that internal liability. You at least knew you did everything you could. But as Adam indicated, state officials, people say to me all the time, right, you don't get into trouble for a bad outcome, you get into trouble for not doing something. So people, where it is now is if you don't do this, you set yourself up. But more importantly, to that point, it protects people for doing what they think the right thing is. Ultimately, despite whatever outcome there might be.
Are school counselors using full or screener version?
I think school counselors, I would say, very often use the full for the first time, right? So you at least, and that still takes like a minute or two, and you get a fuller baseline to go from when you're tracking. When you, as I said, recommended, check in every time, of course you can use the screener, and as Adam probably said, the screener can have the next steps on it. So, and also with this flexible toolkit, many times school counselors put the risk page on top of the full, right? So you have the risk and protective factors, and that's actually what the Tennessee Crisis Assessment Tool decided to do. They took the screener and put the risk page on because if somebody goes to a call and they can't get any direct information, they want to have gone through the risk factors. That's not standard, but that's just showing the flexibility.
someone doing
is there a greater risk for students who are doing extreme self-harm behaviors, has cut their entire body, any reachable spots? We know that the two biggest risk factors for suicide, a history of a suicide attempt is number one, and the biggest cause and the second risk factor is a history of depression, right? Because that is the biggest cause of suicide, this treatable medical genetic illness. And there are these other risk factors, and non-suicidal self-injurious behavior is one, okay? But, it's not up there with those other main ones. And so clearly that speaks to general risk, but I'm not sure that it tells you really anything specific about their suicide risk. So again, we're here, if you need anything, and really thrilled to be able to do this with you today.